Great. So I think, we've got quite a few on. With that being said, I'm going to go ahead and get started and introduce Mary Ann. Just as a reminder, we we did have sponsors this year. We had 2 platinum sponsors, Technion and SG2, and QuadraMed was our silver sponsor. We did give away 2 Echo Dots, and congratulations to those who were our winners. I think it was Jana and Christy, if I remember correctly, but if I didn't, sorry. Just as a reminder, we are giving away or giving CNEs and HIM-CEs. So you must attend 100% of the session, and at this time we have no conflicts of interest with any of our speakers, and we will post information about the event and the presentations at this website, which I will email out later. So I'm going to stop sharing at this point. And I want to take a minute to introduce Mary Ann, who I'm getting to know. I actually just learned we both have something in common, and that's that our sons have or are serving in the military. So that's, thank you to her sons for their dedication. Mary Ann has, she's a nurse who works at John Peter Smith. She's been there for, I think, over 10 years. And she works in the Injury and Prevention Center. And they're doing a lot of really cool things to help refine data collection so that they can identify people who are having issues, not issues, but are in abusive situations or being sex trafficked real time. And that's a really cool, intelligent way to help our patients with the right data collection. And so she's going to talk today about what they've been doing at JPS. They are on Epic. I know she'll go over this, but I think that they've been willing in the past, so I'm not sure if that still stands, but been willing to, share what they're doing in Epic. It's not proprietary. They're not selling it by any means. So if there's, at the end of this conference, if people are interested in learning more about it and putting it, learning to put it in their hospitals that have Epic, that would be awesome. And with that being said, I'm going to turn the time over to Mary Ann so that she can get on with her presentation.
Thanks, Teresa. And sorry that I blocked you out, I think, a second ago. I'm going to screen share now. And if you would just give me a heads up and let me know that it is. Can you see the slide?
We can. Excellent.
Awesome. Okay, much better than the last time. This is a do-over, right? As Teresa said, I really appreciate you all being here and having the opportunity to talk to you about using data to expand value in serving populations that are impacted by violence, power, and control. I will say on this beginning slide here, if you have any personal experience with abuse or any type of violence, some of the content may be a little bit triggering, so make sure that you take time to take care of yourself for sure. So I'm trying to move there we go. I don't have any conflict of interest. If you'll see at the very bottom of the picture underneath the doggies there, I have a really special shout out. I'm not sure if Heather is on today or not, but to Heather Scroggins. She is with Parkland Health and Hospital Systems, and Heather and I worked together for several years on this project to get it up and running, and it has been tremendously successful within our organization. So as a part of this presentation, these are your objectives, and you all will have be able to recognize the role that data plays in identifying processes within and process improvement opportunity within your health system. You will be able to identify a validated tool that's very useful in screening for intimate partner violence, as well as recognizing potential victims of human trafficking. And you will also be able to summarize the importance of disseminating accurate data to gain your own leadership buy-in for meaningful organizational change. So today we're going to talk about MOI, mechanisms of injury. So in my role, I use that term a lot. I am the Violence and Injury Prevention Manager here at JPS. We're going to talk a little bit about the social determinants of health, how they impact health, as well as how they impact life outcomes, the significance of creating relationships with community partners and agencies, otherwise known as your village. We'll talk a little bit about the assumptions of screening completion, and assumptions can be detrimental to patients, victims, and to their outcomes. We'll talk a little bit about ways to gain buy-in for organizational change, which can be a challenge, but it is a worthy one for sure, as well as how to use data, which is you all's expertise in implementing an evaluation for practice change, and the expansion of practice base on successful, using expansion of practice based on successful data collection and being able to being open to similar opportunities for organizational change. Okay, come on. So in my work, a lot of people say, Mary Ann, you're a nurse. So what is this injury prevention stuff? Injury prevention is very near and dear to my heart. My background of 40 years of nursing has been predominantly in emergency, critical care, and trauma care. And I kind of literally fell into injury prevention a few years ago in a previous organization. But injury prevention is really important. There's a professional, Larry Cohen, out of the Prevention Institute of Oakland, California, has a model called the spectrum of prevention. And in my practice here at JPS, I utilize this model in all of our outreach and our internal reach processes. And it is a very comprehensive approach to injury prevention. When you're looking at how to change behavior to prevent people from becoming injured and being admitted to a trauma service or to your organization, I look at things like policy. So city ordinances that regulate, for example, speed limits in school zones. That is a methodology of prevention. You can also look at organizational practices that maybe around your hospital, you have speed bumps that also slow cars down, that keep people from being hurt. Coalitions and networks, you can partner with the fast food joint across from your hospital about creating a walkway from the hospital to the fast food restaurant to prevent, again, either patients, families, or employees from being hurt. And we have to educate providers. We educate ourselves. So notifying people that work within my building, if you want to cross the street, we've just put up this new crosswalk that's also going to have some lights on it to keep you safer. We do community education. So perhaps maybe the houses that are around my organization, we let them know that, hey, feel free to use our sidewalk and look both ways so you don't become an autoped to come to our institution, as well as strengthening my own individual knowledge and skills. And that's where a lot of data comes into play, understanding how impactful or how this autoped injuries around my hospital, going from here to there, how much it is happening. So data is really, really important. And injury prevention really is to prevent or reduce the severity of bodily injuries or death that's caused by external mechanisms such as accidents or crashes or falls before they actually occur. So in looking at the data, lots of data, gathering data from, in a trauma center, we have a trauma registry, but gathering data from my trauma center as well as from community partners really broadens the perspective of the work that needs to be done. In looking at the data, you have to keep in mind also the impact that COVID has had on victims of violence. So when you're looking at this data here, I got the data set on the left from the Fort Worth Police Department, and they're gracious enough to share, and I share as much with them as I can as well. And they're gracious enough to share. And you can look at the years 2019 and 2020 and see some really large variations. If you look at under the crime category, the second one, ABI, assault with bodily injury with strangulation, FV is family violence. In 2019, pre-COVID, the strangulation, non-fatal strangulation was 630 in the city of Fort Worth. But in 2020, it was 76. So we're learning all kinds of, as you are, I'm sure, different ways to look at the data that has been impacted by COVID, where I'm making some educated guesses that the reason the strangulation rate went way down was not probably because of a lot of efforts that our hospital does to reduce strangulation, but probably because people couldn't report because they couldn't get to the hospital or they were staying at home and couldn't get anywhere where they could be safe enough to be able to report that. But I look at that data and then I compare that data that the city gives me with some of our mechanisms of injury that we have recorded in the year 2020 on the orange side and within our trauma center and within those numbers. Just of note, our gunshot wound rate is up 30% from 2019 to 2020, which is a huge impact of COVID that we've seen all over. Other ways to look at data. We started looking at data. We use our trauma registry on a regular basis, but we've also started looking at zip coded data and mechanisms of injury. And this is a heat map that shows specific areas where intimate partner violence strangulation was reported. The 76116 area, which is in West Fort Worth on this map, has the highest level of intimate partner violence strangulation in the area. So these are things that I've been considering in this past year. Another way to look at data that's broken down by zip codes is through assaults. And I'm comparing the two different zip coded areas of 76116, which is dark, which has a lot of assaults, the darker the more, and 76104. Each of these zip coded areas show very high rates of assaults. So in knowing this, this helps to really shape and format in my head and my team's head, where is it that we need to focus within Fort Worth and in Tarrant County some of our efforts and our approaches. Keeping in mind the areas of gunshot wound, I mentioned earlier that our gunshot wound rate here for admissions is up, and I said it's up 30%. It is significantly high. You can see the pattern again in those same two zip code, or in the zip code of 76116, the darkest there is in West Fort Worth, has a super high incidence of gunshot wounds. And being able to compare the city zip code with our trauma registry zip codes is interesting, but it's very informative on telling us where we need to conduct our outreach efforts. So, you know, hospitals, we typically, when you think of a hospital, you think about people coming in and we take care of people here for our injuries. But because we are a level 1 trauma center, we are required to go out into the community to look at the city data, the county data, and some national data even to compare with. We're required to go out to see what we can do, be upstream, and actually mitigate that trauma before it even arrives to our hospital. I always, when I give talks, I talk to people and say, I really am just trying to put us out of business as a trauma center. That would be just like the ultimate goal. And I get a little nervous saying that around my administration. But we know that's never going to happen. But we all want to reduce injuries within our community. Now, the CDC tells us about, when we talk about social determinants, they tell us that there's a disproportionate risk for violence that is based, conditioned on inequities due to race, socioeconomic status, due to gender, where people live. We know that there are communities where people are much more vulnerable to violence compared with other communities, and we're going to talk a little bit about that a little bit later. And when looking at all of this data, both from the city and from within my institution and from within other people that are in my village that I'll talk about in a minute, looking and comparing all this, you really get a really broad spectrum, high level view of what's happening around us, why people are coming in, and what are some opportunities that we can use to mitigate. For example, in some of those heat maps that you saw, I mentioned that we focus on a couple of different zip codes, and one of them is in 76104. And that's the actual zip code where my hospital sits in the city of Fort Worth. And data has told us that in the state of Texas, 76104 has the lowest life expectancy in the entire state. It is a very poor area, riddled with a lot of violence, no street lights, no walkable stores, no walkable sidewalks. All of these things impact why people come to my hospital to be taken care of. In the social determinants of health, talking about this again, using the data regarding the zip coded areas that I showed you in the previous slide has directly influenced where our shift of focus for injury and violence prevention occur. Social factors that shape people's health, including education, income, wealth, and other conditions where we live, learn, work, and play, are also strongly linked to violence. And considering these links and how they can contribute, and considering the links that contribute to understanding why there are certain groups of folks that are more affected by violence than others. It doesn't happen a lot in my neighborhood, but people can be exposed to violence in many, many ways, and they may be victimized directly, or they can witness violence or property crimes in their community, or they can hear about crime and violence from their other neighbors. So we need to consider addressing exposure to crime as a public health issue, because that can help prevent and reduce the harm to the individual within that community as well as their well-being. We talk a lot about the social determinants, the neighborhood, the built environment, where you live. Do you have access to health care? Do you have value where in your own community? Do you have contacts? Do you have your village people that you can rely on, your friends and your neighbors? Do your parents or your parent or your caregiver value education? Do you have access to a library and to books? And then there's the job thing. And we certainly know that during COVID, our economic stability, as well as many of the other social determinants of health, have been greatly impacted. So this slide and this pie chart reflects how where people live impacts their likelihood of being a victim of violence. If you live in a mid to high income neighborhood, you have about an 18% likelihood of becoming a victim of violence. But if you're living in 76104, where my trauma center is, that has a very disadvantaged and lower income neighborhoods, it's almost a 50% chance that you're going to become a victim of violence. And we just know that from the CDC. We know this from a lot of different data sources. So in healthcare, I think we're really growing and we're really expanding on how we look at what healthcare is, what it has the opportunity to be. The CDC recommends, this is CDC recommendations for vulnerable populations and for violence prevention. So we need to have individual level interventions, going out into the community, teaching people life skills. We need mentoring programs and peer programs that promote, those trusting relationships, those neighborhoods that can rely on each other. We need social norm and marketing campaigns that reflect positive and community and togetherness characteristics that, we are the world and we care for each other. These are very lofty goals, but we know, and while we laugh sometimes about, that type of a goal, this is really important in reducing violence and injury within our neighborhoods, within our community, within our state, and within our world. So shifting just a little bit, and now we're going to get into a little more meaty. I wanted to give that basis of the social determinants of health and the prevalence and risk parts about where you live, work, and play, and how that plays into the potentiality of becoming a victim of violence. So in intimate partner violence, now we all know through data and research that intimate partner violence impacts everyone. It doesn't matter where on the socioeconomic ladder you are, where you live, we know it can happen anywhere. But what it is, intimate partner violence or domestic violence interchangeably, is an abuse or an aggression that occurs in a relationship with a current or a former partner or spouse. There's 4 types of bad behavior. There's physical violence, and that's pretty self-explanatory. There's sexual violence, being forced, whether they're married or their partners. There's stalking, which is often repeated, and we have laws against that in the United States. Again, on that spectrum of prevention, changing policy to help reduce injury. And there's psychological aggression that occurs, and it's at the bottom of the list, but this list is not in any particular order. Psychological aggression, we're learning more and more through research and science, the impact that has on our brain development, and the way that we see the world. So a little more local. Well, first nationally, sorry. Nationally, it's 1 in 5 women and 1 in 7 men report having intimate partner violence. About 1 in 5 women and 1 in 12 men have experienced sexual violence by an intimate partner. This nearly half of all female homicides in our country are killed by their current or their former male intimate partner. In Tarrant County, where I am, it's 1 in 3 women. So our numbers are a little bit higher than the national numbers that have experienced intimate partner violence, and 1 in 7 men. In 2019, the year before COVID, I hate that word. I'll be glad when we can not say it as much. In 2019, half of all violent crime in Tarrant County was related to family violence. That number was skewed in 2020, but I wanted to put the year before COVID so you could see about where we normally are. So this is the screen for intimate partner violence that we were using in the past. And in 2016, this became a huge focus. 2016, JPS became a member of Tarrant County's Adult Fatality Review Team, which looks at fatalities that are caused by intimate partner violence. And this was put out by our county commissioners court because of our higher incidence, even than the national average, of intimate partner violence. So when we looked at some of our data, and beginning in 2016, we took a really big deep dive into our electronic health record within our emergency department for screening compliance. And we used this particular screen that you're seeing. It's not a validated tool, and we could never really figure out if it was the standard tool from the vendor, if it was something that we created. We didn't really know what the author was, but we found that we were only screening about 12% of all of our trauma patients. And that was just trauma patients. And this tool is not a validated tool. And it's really, when you use tools, either electronically or not, but we're all pretty much electronic now. When you use tools that are not validated, it's really hard to collect those succinct data points in order to measure outcomes, in order to measure compliance, in order to measure referrals. I mean, the second question there, what happens when you argue or fight with your partner? That requires the screener to manually input, what's happening. And so it's really hard to kind of do any type of consistent monitoring of compliance. And also, what was interesting is that it really didn't have a definitive diagnosis per se of abuse. It wasn't like a yes or no, because if I am screening and I've been in a bad relationship within my lifetime as a child and getting married, yeah, we duke it out when we fight and scream. That's normal to me. And a lot of people have not seen or been modeled a normal or a healthy, I shouldn't say normal, a healthy relationship. Now, We also discovered a few other things. And thank you, Heather, again. You inspired me, and I expanded on some of your illustrations here. So when we screen, we make a lot of assumptions, right? We discovered through use of focus groups when we were first looking at this work, we discovered that the person that was doing the screening was often not at all in any way connected to that patient. And when I say connected, yes, they're in the same room, but they're not really engaging. They're not really having a trusting moment or creating a safe space for that patient to be able to disclose what could be happening in their house. Creating that space for patients really builds trust, and they begin to trust their providers, and then that really contributes to successful screening. And successful screening in no way means we've got them into the shelter, they've divorced their person, or they've left that person. That's not the success. The success is providing the information, relaying it in a digestible way to that patient, for that patient to make their own decision as an adult, not a minor, this is as an adult, to do what they know is best for them at that time. What research also tells us is that eye contact is super important in having essential and meaningful conversations. You guys okay? All right, heard a little conversation going on in there. Okay, so.
Yeah, if everyone will make sure they're muted.
Yeah, make sure
We
you're
had someone
muted.
just get on. If you're not muted. Okay, thank you.
Thanks, Teresa. Anyway, so we started looking, looking for best practice, looking for validated screening tools, and also at the same time listening to the nurses that were working in the emergency department. Please don't make me do one more thing, because we know that it is such a hard thing to add one more thing for that nurse to do. We all know that. That's very difficult. But we partnered with our research department to determine what was the best tool to use in the screenings that could fit, thank you, Heather, again, with the ED workflow. We found a validated tool that had a Likert scale for a definitive recognition of intimate partner violence or potential violence in the home. And it was created by Dr. Kevin Sheeran, and it's called the HITS tool, hurt, insult, threatened, or screamed, which spells HITS. This tool also gave a numerical score at the end when you asked the questions on this Likert scale. It gave a score that let that nurse know, here's a warning signal. You get a 10 or a higher, that means you're at risk for violence in your home. So we found that. And then we started thinking, well, okay, here we've got this great tool. Now, how are we going to convince everybody to use it? Because nurses often, and I'm a nurse, so I can own this and say it, we want to fix everything. If you have strep throat, I want to give you your penicillin. If you have a broken leg, I want to make sure you get to the ortho doctor. We've got to fix it all. And so with intimate partner violence, there isn't a pill, there isn't a cast, there isn't, something we can physically do to fix that. So we went out into the community to see what's out there that can help, what's out there that can provide resources for people that are being victimized. So our community partners have provided foundational success for the program that we have here at JPS. They have incredibly rich resources. They've got safety planning, screening education, and we brought these people from this village here that you're looking at, from the Health Science Center, Tarrant County Challenge, Genesis, the Women's Center, One Safe Place, the police, the sheltering organization, Safe Haven, the district attorney's office, and Unbound, our human trafficking organization, our local one. We brought them in, and this pre-COVID, we brought them into the hospital and we let them meet the nurses. We had lunches, we had quick times during huddles where they could talk about the work that they do and how that they can help the patients that we see here at JPS. So these members in our village don't not only serve our patients. What that did when we brought them in is it brought the confidence level to our staff way high. So the nurses were like, holy cow, We can screen them, we can identify them, and somebody else can fix them. We akin it to a life gift consult, in that when nurses are caring for critically injured patients that end up passing, we call life gift for organ donation, and that nurse doesn't continue to care for that patient once we hand them off to life gift. So this is a warm handoff to all of our village people, to all of our community partners, and those warm handoffs are super important for program sustainability. Our teams trust our village, which is cool. Okay, so we've got the village, we've got the screening tool that we're looking at, and so we need some rules, right? Policy back into the spectrum of prevention. So we, the Joint Commission, they were just here last week. We did super good. The Joint Commission requires that we do some type of screening for domestic violence. We know for domestic, we know for elderly and pediatric, we have to do something. They don't tell us what we have to do. They don't tell us what our practice should be, but we do have to do some type of screening to identify victims of domestic violence. So we formed some focus groups, and with our focus groups, we picked specific intake units. We picked some that we didn't know for sure if it would even matter. One of our regular floors, you know, how high would it be there? But we wanted to look and see what screening looked like using a validated tool, engaging with our village and our community partners. And we went to different units, we have several family clinics. We tailored education to each of those specific areas because the workflow is very different. We know that across the hospital. If you plucked me out of the ICU and told me I had to go work in the ER, the ICU nurse would, what? I don't know how to do any of this. And the ER nurse the same in the reverse. We used our nurse residents here within our own organization as the focus group, and they identified barriers and they identified biases, but they also gained some staff buy-in and educating at the same time while they were doing these focus group screenings and interventions. And it made it very compelling to the staff. So in our electronic health record, this is a snapshot of what the initial part of the HITS tool screening is. And so what we found back when the residents went in, what we found is that they came back and they said in our focus groups, and I really listened to we really listened, we recorded it, we listened. They said, we don't like asking how often does someone physically hurt you first? Because that is like a very intimidating question, which was very strange to me because as a nurse, I've told people they have sexually transmitted diseases and, how to practice safe sex and all these kinds of very personal things. But the nurses were super intimidated by that. So we contacted Dr. Sheeran and asked him, can we flip some of these questions around? Can we change the order? And he was like, yeah, it's still a validated tool. He just put it in that order to make the HITS spell HITS. So really ours is kind of like the itch screening, it's not really HITS. But anyway, so when we flipped them around and changed the order, what our data showed when we went back and looked at it was the compliance level just bam, went way up. It was really helpful to listen and to use and to take our time as we were rolling this out. And that's an important point because as a prevention person and as a nurse, I want to hurry up. I want to get this done so we can help more people. But in slowing down a little bit and looking at our processes, both with very specific training and noticing workflow in different areas within our organization, where to put the screen, as well as listening to the nurses about what they did like or didn't like, made a big difference in our success. And we're pretty successful. We'll go over some of that data in just a second. So I want the compelling consequences. So as well as talking to people about doing their screening and listening to the nurses, a lot of our nurse residents came back and they had engaged with the staff in different areas of our organization. And one of the comments that they made was that, the nurses and the techs and even some of the physicians were like, these people that are in these relationships can just leave. You know, why can't they just leave? So we're going to talk a little bit about how important it is. The data is very important, as well as the story behind the data. So the consequences. We know through research that there are a lot of negative health outcomes that are associated with intimate partner violence. It is it impacts the heart, the digestive system. We know that when people are under stress, much like in the ACEs study with children, adverse childhood experiences, the experiences that you have impact your entire body and all of the different health systems within it, your reproductive system, your bones, your nervous system. Patients who are impacted by intimate partner violence suffer from traumatic brain injury, from chronic traumatic encephalopathy, much like our football players. They have chronic concussive syndrome. They can develop depression and especially PTSD, as well as early onset dementia. Exposure to violence and abusive behavior, whether you're an adult in a relationship or a child growing up with adverse childhood experiences, has a tremendous impact on overall health and well-being. So in intimate partner violence, and we're going to do a little bit of comparison here when we're talking about patients who are victims of harm, crime, and make sure you're muted, harm and crime and injury. In Duluth, Minnesota, they have done a lot of studies on intimate partner violence. And they developed a scientific study that talks about power and control. What is intimate partner violence, as well as what is human trafficking? It is all about the power and the control one person has over another. There's a lot of similarities in the victimology between intimate partner and human trafficking. Both of these situations produce manipulative, vulnerable victims. So there's some similarities. Human trafficking and intimate partner is about abusing and using power and control. And we know that violence affects health-related behaviors when you witness it. As I mentioned earlier, talking about the ACEs study, both intimate partner and traffickers use a lot of psychological and physical threats. They use emotional threats. If you don't do what I say, we're going to hurt your family. They isolate. So there's a lot of isolation in both of these types of maltreatment. Lots of isolation. They get people away from their village. They get people, remember the social determinants, it's kind of all tying in. They get people away from their neighborhoods where they are safer, and they isolate them where they can control their behavior, what they do, all the way down to what they eat, how much money they can have. They use a lot of coercive tactics to threaten that person, to get them to comply. And that person will comply after a while. So let's talk a little bit about trafficking. That was just kind of a little short introduction into the trafficking. So trafficking is exploiting a person, and there's essentially two types of trafficking. There's labor services, or commercial sex. So you can read there what the Trafficking Victims Protection Act is. There's sex, like I said, and then there's labor, and that's just the legal definition there for you to have. What we know too is that the National Human Trafficking Hotline informs us that Texas is the second, is number 2 in the nation for trafficked victims. And well, I'll tell you a little bit more in a minute. So here's some more Texas data. So human trafficking in Texas, this is from 2020. You can see the numbers there, right? Texas, most of our trafficked people are labor trafficked. And you know, we have a lot of awareness around sex trafficking. We have a whole lot of awareness around child sex trafficking, and we need to have all of that. But we also need to remember that what the data is also telling us, something that can be overlooked, is these victims that are labor trafficked. So top areas for labor trafficking is domestic work, housekeeping, things like that. Top venues in Texas for sex trafficking is in some of the massage parlors, the spa businesses. And people that traffic don't look like the big bad wolf. The traffickers don't look like Freddy Krueger. They look like grandma. They look like aunts. They look like moms. They are students in high school. We are finding what traffickers look like. We have had multiple incidences here of recognizing young children coming in with aunties and uncles, and I'm the grandma with no proof of anything, different names, and we've seen that a lot here in our own institution. So it's just a little bit of information there. So in our screen, we have red flags. They're just observations. They're not questions to ask the person. It's just an observation. And you can see what they are: odd or changing story behind what happened. We have had patients come in and say, well, I came in and I fell because I slipped on a wet floor. And then they get in the back and they said, no, really, I stepped in a hole in the ground. You know, their story is not succinct. It's not making sense. Other people that are with the patients that are injured or coming in for maybe not even injured. Maybe they're coming in because they have a stomach ache, but somebody else is talking all the time for that patient. The patient's not answering the question at all. Suicide attempts are pretty high, with an observation that people need to think maybe something's going on. And you can see these observations. And we also kept put in there a gut feeling, because we all get those. You know, we have that response in our brain that has, you know, it doesn't go away with evolution. You get that gut feeling when something isn't quite right. So that is also an observation. So human trafficking and our strangulation question will cascade open, because we don't need to screen for human trafficking in every patient. That's a waste of nurses' time and screeners' times in the entry points at the hospital. So if they had a HIT score of 10 or greater, which is significant for violence, if they have any of the red flags, or if they have a combination of both, and that's when the next, we'll talk about the next screen that pops up with regards to further questions about intimate partner. You heard me mention strangulation. So research and data tell us that nearly half of all women in intimate partner violence relationships have experienced non-fatal strangulation. I was in court yesterday waiting to testify in a felony strangulation case for several hours, and on the stand for over an hour. And it's pretty prevalent. And if you see these photos of these women here, both of these women could have experienced non-fatal strangulation, because in about half of the time there are no marks on the neck for strangulation. So we ask a question about strangulation in that screening, and the question you can see is, has your partner ever used their body or any other object to forcibly strangle or choke you? Now, we know that choking is internal. Choking is, I've eaten a big bite of steak, or, you know, laughed while I've had something in my mouth and gotten choked. But strangulation is external, so it's a little bit different. But our people who come to our hospital, our patients that we care for, are often, they just, oh, I just got choked out, I'm fine. So we include that language, and that's important when you're talking to patients, to use words that they understand. And if they say yes, we ask them, well, did you have difficulty swallowing? You know, check all of those that apply. The sore throat is the most common complaint from someone that has been forcibly or has had experienced non-fatal strangulation. The woman on the left is what typically people look like, even when they're in the medical examiner's office. In fact, a lot of what we know about strangulation comes from data collected from the ME's office when they do an internal autopsy, and they can see the damage. The one on the right-hand side is a young woman that was trying to get away from her significant other, and you see she has petechiae. Petechiae are little burst blood vessels caused by the congestion in the vessels when that pressure is applied to the neck, and the blood can't go up or down, and after the congestion gets big enough, it just bursts. and makes petechiae above the level of strangulation. She also, and I don't know if you can quite see it on your screen, but she also has scratch marks on her neck. And if you think about that, more than likely, she did not remember. More than likely, as she was trying to get the hands off of her neck, she probably scratched herself. So this strangulation is really important because when we ask it and in person, face to face, in a safe space, right, we let that patient know that if they have experienced non-fatal strangulation, we let them know what research and data tells us is that strangulation victims are about 800 more times likely to become a victim of homicide, which is really good when you need to make an important decision. You need to have all of that information that you can in order to make a good decision. And so we do let people know that, not to scare them, it probably does, but to make sure that they have the information they need to be able to make an informed decision. So again, if they're positive for hits and if they have observational red flags, this pops open. It doesn't pop open on everybody. We're averaging, oh, I think I'll tell you that in a minute. So this pops open, and we don't have a validated tool in healthcare yet for screening human trafficking. We talked a little bit earlier about the importance of utilizing a validated tool in order to ask good questions, in order to collect great data, but there isn't really one for human trafficking. There is in law enforcement. It's about 60 questions long, and I would be strung up if I asked the nurses to ask 60 questions to determine if someone is being trafficked. But these are our current screening questions. And any answer with an exclamation point as the nurse clicks on it, makes it workflow again, is super important. As the nurse clicks on it, or as the screener clicks on it, if an exclamation point appears, then that means it's considered positive. So then if all they have to have is one exclamation point to be considered potential human traffic victim. And we very intentfully use the word potential in there because that is not a validated screening tool. So here's some of our data from 2020. This is straight out of our emergency department. And when we initially, when we initially went to administration to try to tell them we weren't monitoring for victims of violence, vulnerable people within our organization. We weren't really screening for vulnerability, for victimology, and things like that. And we let them know. We let them see the data at the time, 12%, and they're like, "Oh my gosh, we need to do something better in order to gain support from our administration." We also had some successful stories to tell them of people that we had helped. We also had some stories to tell them of people that we had missed. And that's really important. The numbers are really important, but we all have tremendous hearts in healthcare. And it's important to let our leaders know what we know, just like it's important to let that patient know that if you've been choked out, your odds of being a homicide victim are 800 times higher. So having that knowledge to make a good decision helps to sway the administration. And so this data, again, is from 2020, and it shows us the total numbers that were screened, our positive hits, our positive possible human traffic numbers, and then the referrals. Remember, back to our village. And then we also thought, you know what, people are adults and they can refuse, and they don't have to go anywhere or accept any help if at that time they don't want to. But we want them to know that when they come here, every single time we're going to ask those questions, and that will build that trust, and maybe one day they will make a different decision. So policy. So we talked about not only the Joint Commission requirements, but we also have an internal policy that has now been updated in our system that lets people know what to do if they encounter, or what to do if they suspect either intimate partner or human trafficking, or if they don't know how to refer. It's in there. So we've really, what we've been doing in recent months, in our own communities, in our state and national data COVID have been showing a huge increase and rise of assaults and gunshot wounds and other violent crimes. People are just, we're a mess right now as a country and as a world. So we started looking not only at intimate partner and human trafficking, but we're looking at vulnerable victims. I mean, these people all have a lot in common through their social determinants of health. We can like point at things that they all have in common. So we've begun to add even another layer of service, and this is super exciting. We just started this. We have we've added a forensic team. We have a same team, forensic nurses, but now we've added a couple of other nurses, again, kind of piloting. We're starting small to see what works, what doesn't work, look at the focus, look at the workflow. And we have these two forensic nurses that not only respond in the emergency department to any type of violent crime or any type of crime victimology, as well as they go into the hospital and see patients. And they are trained for forensic interviews, creating that safe space. They know about the community village services that we have. They can help apply for crime victims compensation. And along with those two forensic nurses, we also have added an additional layer of licensed clinical social workers who have extensive knowledge in trauma-informed care. So, you know, again, the motivational interviewing, the listening, the safe space, the bonding and the trust. They are also in our ER stationed there, but they go all over through the hospital because we are beginning to really just touch that tip of the iceberg of what our society and what the people that we serve in our community are beginning to show us, and we're listening and what we can do. So we can't just look at them in here. So now we're doing in-house that type of victimology, but we're also doing outside. So I told you about our increase in gunshot wounds. We've also had a tremendous increase in stab wounds. So now we're going out into the community and educating community members how to avoid violence. And for us, that's like, duh. But, you know, for people who live in poor areas, who don't have access to education, who don't have access to so many resources that we are fortunate enough to have access, they may not know. So we teach our community members about de-escalation, about conflict resolution, about what to do when you get pulled over by the police. And then we also, yes, we do that. Yep. So we also have begun to outhouse, and then again inside, some of our victims that are here because of violent crime. We have now connected with our we're pulling in our psychology department because we discovered that through research that when people are assaulted and have a violent act upon them, they develop acute stress disorder, which in a few days can lead to post-traumatic stress disorder, which leads to, again, more risk behavior and a lot more recidivism. So we're able to refer all of our victims to different community resources, give them the tools that they need, and utilize our help from our medical team in our psychology department. So all of that being said, when you have data equals an increase in knowledge, it also, data tells us the practice change, you know, going from 12% to about 70% right now in our ER. And what that does is it improves the outcomes for our populations that we're serving or have not had to serve because we're out there in that community. And so what this is my favorite quote, is do the very best you can until you know better. And then when you know better, you do better. And I'm not going to go over that. If you want to take a screenshot of some of the community resources that we work with, here is your chance, 3, 2, 1. And now I'm going to stop screen sharing. Okay, I stopped it, didn't I? Right?
Yes.
You're not seeing my screen. Okay, cool. All right, and I think we're right at, we have 4 minutes. So,
Well,
That was a
an
lot.
excellent. That was an excellent presentation. I mean, for me, this really brings home how you can take data and make it actionable, and how you use so much data to even begin the research to know where you need to start, and all the different ways that you use the data to get to where you're at. So I really appreciate that, because a lot of what we're trying to do in healthcare from the analyst standpoint, from the clinical informatist and all of that is, how we can collect all the data in the world, but it doesn't mean anything if we can't, make it actionable and improve our health of our community and all of that. So with that being said, if there's anyone who has questions, you can post them in the chat. I see Mary said fantastic presentation.
Thank you.
And if you want to ask your question, you are welcome to turn on your camera and speaker. If you have any questions, I thought it was, how y'all found the different data collection tools, that was kind of amazing. And so, uh, if anyone,
yeah. And that is very helpful, and really to get a bigger picture of what's happening, in your community. So if you guys have other questions, or if you just want to shoot me an email, I put that in there. If you need anything, I'm happy. We share everything because it's working. And, if it's working, we need to share it. And because we are all a part of this, and making our communities healthier and making ourselves healthier. So
we do have a question from Maria Fuentes, I think. How long did it take to get the screener tool set up in your EMR for the staff to use?
That is a great question. Normally, we know that takes a little while. I was very fortunate at the time to work with Heather Scroggins, who was on the informatics team. And so we got some favorable treatment, preferable treatment from Heather. It takes a while. I think from beginning to end, it probably took us maybe 2 months, 3 months. We wanted to make sure we tweaked it so much. We did it all on paper first. Before we tried to put it in the electronic health record, we were really mindful about that. And so we didn't want to have to go back and redo and redo and redo. So it was probably, oh gosh, I wish Heather was here because she could probably answer that. 3 months, something like that. A while.
I actually think that that's pretty fast to implement a tool. So I don't know, maybe I'm old school, but sometimes it takes time to implement these things. So I don't know. Yeah, Maria agreed. Fast.
It must have been longer. It must have been longer then. I don't know. Heather would know that one. Sorry.
So that's great. Are there any other questions before we wrap up for the day? I'm sure, Mary, you'll probably get some emails, because this is a lot to think about. And, this is a great tool for those analysts that are on community health teams that are trying to make data actionable in the community. That's a big deal for the hospitals now. They're really trying to get involved in the community. All our hospitals are, and how they can help. And so, this is a great tool for those analysts that are working on those informatic teams. So I hope that people will take advantage and reach out to you. And again, we will make this recording available along with her slides. So we will send an email when all that's uploaded. And with that being said, if we don't have any more questions, and being mindful of everyone's time. Oh, we got someone clapping. I think that's Mary. Yeah, I'll do my jazz hands. There, yay!
I appreciate the opportunity for the do-over, for sure.
Thank you so much, and everyone have a great day. And we'll be sending out the evaluation survey tool for those who want to get their credits very soon. Thank you.
Thank you. Guys, have a great afternoon. Thanks so much.